So let's talk about the patient with alcohol or substance use problems. We need to go through this quickly. We have no much time. So start with case summary. Mr. AD, aged 42 years, presented to his general practitioner, smiling, smelling. Okay, again. Mr. AD, aged 42 years, presented to his general practitioner smelling of alcohol and complaining of depression, anxiety, relationship difficulties, and erectile dysfunction. He admitted to drink up to a bottle and a half of whiskey per day. He reported drinking increasing amounts over the past year, as the same amount no longer gave him the same feeling of well-being. Recently, he noticed that he had to drink in order to avoid shaking, sweating, vomiting, and feeling on edge. These symptoms meant having to take 2 glasses of whiskey before breakfast just to feel better. Mr. AD admitted that he had neglected his family and work because of his drinking. Whereas in the past, he would vary that, and when he drank, he now tended to drink exactly the same thing at the same time each day, irrespective of his mood or the occasion. He found himself craving alcohol and felt unable to walk home past the pub without going in. He continues to drink although he knew it was harming his liver. He was also concerned about his mental health because on more than one occasion he thought he saw a witch about the same height as the kitchen kettle walking around the room. He decided to contact his GP after he was charged with drink driving by the police. Mr. AD had no previous psychiatric history or family history of psychiatric illness and was not taking any medication. We will discuss this case next at the end of this chapter. Psychoactive substances have been used for centuries, and their use is seen in many cultures as entirely acceptable. They have many beneficial effects, including relief of pain and distress. Without them, life would be grim for some. However, psychoactive substances may cause symptoms and behavior changes which are damaging to the individual or those around them, particularly when the substance is used regularly or to excess. Initial use of a substance can lead to a cycle of further use, even when the person wishes to stop. As many recreational substances are associated with dependence, and withdrawal can be unpleasant, and with a minority of substances, fatal. To talk about some definitions and clinical features. The term psychoactive refers to any substance that has an effect on the central nervous system. This includes recreational drugs, alcohol, nicotine, caffeine, prescribed or over-the-counter medication, and poisons or toxins. This section will introduce 5 concepts in relation to psychoactive substance use: intoxication, hazardous use, harmful use, dependence, and withdrawal. So we have these 5 concepts: intoxication, hazardous use, harmful use, dependence, and withdrawal. We have this figure that provides an overview of these and some other substance-related disorders. Okay, for patients report psychoactive substance use, if you have transient behavioral, perceptual, or cognitive symptoms shortly after the use, this is intoxication, which can present as delirium if severe. So these intoxication is about the transient behavioral, perceptual, or cognitive symptoms shortly after use. If use places at high risk for harm, this is hazardous use, when the use causes risk or harm. If use causes harm but not dependent, this is harmful use. So hazardous use places person at high risk for harm, but harmful use, it does make harm. It did actually make harm. It would be substance-related cognitive disorder or substance-related psychotic disorder, substance-related mood disorder, substance-related anxiety, any kind of these, you know. No. It's something. Yeah, of course. Okay. These are some, some options for that. If dependence syndrome happens, this is dependence and may be associated with these. If the patient that reports psychoactive substance use and when stopped abruptly, depending of course on substance and the extent of use, if there is no symptoms, that's okay. But if there is withdrawal syndrome, there may be some withdrawal symptoms, mild or severe, or can be withdrawal with delirium. These are the options here. So this figure is talking about, the diagnostic approach about the use of psychoactive substance use. So some persons would use some substances to cause intoxication, just like that. If it puts them under risk, this is hazardous use. If it makes some harm, this is harmful use. If dependence happened, we will talk about dependence more. But if dependence happened, this dependence. If when stopped, no symptoms, that's okay. If with withdrawal symptoms, that's withdrawal syndrome. If with withdrawal and delirium, this is withdrawal with delirium. So let's talk about these definitions. Substance intoxication. Substance intoxication describes a transient substance-specific condition that occurs following the use of psychoactive substance. Symptoms can include disturbances of consciousness, perception, mood, behavior, and psychological functions. Severity of intoxication is normally proportional to dose or levels. Hints and tips. Hazardous use of a substance. Hazardous use is a widely used term introduced by the WHO and the National Institute of Health and Care Excellence, but is not in ICD-10. Hazardous use of a substance is defined as a quantity or pattern of substance use that places the user at risk for adverse consequences without dependence. For example, drinking alcohol above the recommended limits is hazardous use, whether or not the person feels they have come to any harm. This is hazardous. If it causes harm, this is harm use. Harmful use of substance. Harmful use of a substance is defined as the quantity or pattern of substance use that actually causes adverse consequences without dependence. It may result in difficulties within interpersonal relationships, like domestic violence, erectile dysfunction, problems meeting work or educational obligations, like absenteeism, of course, impaired physical health, like alcohol-related liver disease or trauma, worsening of mental health problems like low mood or anxiety, or legal difficulties like arrest for disorderly conduct or stealing to fund habits or drinking driving. Okay, let's see something here. About communication. Remember the 4 L's: love, livelihood, liver, and low, as a framework for assessing harm arising from substance use. Love, livelihood, liver, and low. Substance dependence. Hints and tips. The confusion regarding use of the term addiction led the WHO in 1964 to recommend that the term be abandoned in scientific literature in favor of the term dependence, because this addiction is general term, so we have this dependence thing. Communication. Substance misuse is a general term used to refer to substance use without legal or medical guidelines. It includes both harmful or dependent use of substances. Substance abuse has the same meaning but is usually avoided because it has negative connotations. Okay, misuse. Substance dependence describes a syndrome that incorporates psychological, physiological, and behavioral elements. So you can see that in the next box. Here we have the ICD-10 criteria for dependence on a substance. First, a strong desire or compulsion to take the substance. 2, difficulties in controlling substance taking behavior like onset, termination, levels of use. Physiological withdrawal state when substance use has reduced or ceased, or continued use of the substance to relieve or avoid withdrawal symptoms. 4, tolerance where increased quantities of the substance are required to produce the same effect originally produced by lower amounts. Priority given to substance with neglect of other interests and activities due to time spent acquiring and taking substance or recovering from its effects. 6, persistence despite harm where use of this substance is continued despite a clear awareness of its harmful consequences, either physical or mental. So here we have the criteria: desire, difficulty in controlling, withdrawal, tolerance, priority, persistence. So that's it. That was the books that talk about, these elements. If patients exhibit either tolerance or withdrawal, they may be specified as having physiological dependence. However, patients can meet the criteria for the dependence syndrome without having developed tolerance or withdrawal. The dependence syndrome is diagnosed if 3 or more of the criteria have been present together at some time during the previous year. So, okay. Hints and tips. So let's just remind you of these things in the box. We need just 3 of these: strong desire and compulsion, difficulties in controlling that, withdrawal, tolerance, priority, and persistence. So it's not just tolerance and withdrawal. Yeah. Okay. Hints and tips. Patients are physiologically dependent on psychoactive substance when they exhibit signs of tolerance and or withdrawal. Substance withdrawal. Substance withdrawal describes a substance-specific syndrome that occurs on reduction or cessation of psychoactive substances that has generally been used repeatedly in high doses for a prolonged period. It is one of the criteria of the dependence syndrome. So this is substance withdrawal. Okay. Let's talk specifically about alcohol. Alcohol-related disorders. Many people who drink alcohol come to no apparent harm. However, drinking even a small amount of alcohol without overt harm at the time increases the risk for many subsequent illnesses like cancer, stroke, heart disease, liver disease, and also death through accidents like head injuries, fractures, facial injuries, and so on. This increase in mortality outweighs the potential health benefits of moderate consumption, which are limited to a small reduction in risk for ischemic heart disease in women over 55 years old or drink around 5 units per week. The chief medical officer advised that there is no safe level for alcohol consumption. However, for many people, alcohol is a large part of their social lives, and they may feel the benefits of consumption outweigh the risks. Similar decisions are made by those who choose to partake in high-risk sports. For those who choose to drink alcohol, a number of steps can be taken to keep the associated harms to a low level. Well, we see that it's prohibited and it's wrong, but we shall see what they are talking about. They say this: we have some limit on weekly consumption. You should not actually, but we are reading here. So you should drink no more than 14 units per week, male or female. Regularly drinking more than this means your lifetime risk of dying from an alcohol-related condition is more than 1%. What does that mean? 14 units per week, which is so one, this is, okay, what's that? Okay, 1 unit is 40% spirit in 25 milliliter, while 4.8% larger, this is 2.7 pint in 568 mil. 14% wine, 250 mil, this is 3.5 units, I think. So, you spread out weekly consumption, avoid binging, spread intake evenly over 3 or more days, or fewer days if drinking less than 14 units per week. And of course, I don't drink at all. That's the right thing to do. Anyways, reduce risk during single episode consumption. Limit the total amount consumed on a single occasion. No minimum daily limit suggested due to large variation between individuals and contexts. Groups particularly vulnerable to risks of acute intoxication include people at risk for falls or interacting medication, or people with existing physical or mental health problems. Drink slowly with food and alternate with water. Of course, do not. Plan ahead to protect yourself from problems while intoxicated. Plan transport home, drink around people you trust, blah, 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 blah. Anyways, but it's okay to know about these. Hints and tips. 1 unit of alcohol, which is 8 grams per 10 milliliter of pure alcohol. Note this varies between countries. 1 unit is approximately equivalent to the amount of alcohol metabolized in 1 hour. For example, if you drink a large glass of wine, usually containing around 3 units, it will typically be at least 3 hours before blood alcohol concentration returns to 0. So 1 unit is the amount of alcohol that is washed out within 1 hour. Alcohol metabolism follows zero-order kinetics. It cannot be speeded up by drinking coffee. You can calculate units by multiplying alcohol by volume in percentage by volume in liters. So the alcohol volume, alcohol by volume by the volume of in liters, which equals the units. Okay, for example, a pint of 568 ml of 5.3% would contain 3 units. So that's it again. Let's get back to the... You get that. 40 plus 25. That's it. Something like that. Anyways. Communication. The Chief Medical Officer's advice on alcohol consumption can be summarized as: there is no safe level at which to drink alcohol. Drinking at most 40 units per week keeps risks low, but some people will be harmed by less. Don't drink all 14 units in one night. Don't drink at all, actually. Okay. Acute intoxication. Ingestion of alcohol results in transient psychological, behavioral, and neurological changes, the severity of which are roughly correlated to the alcohol concentration in the blood and brain. Initially, this may produce an enhanced sense of well-being, greater confidence, and relief of anxiety, which may lead to individuals becoming disinhibited, talkative, and flirtatious. As blood levels increase, some drinkers may exhibit inappropriate sexual or aggressive behavior, whereas others might become sullen and withdrawn. With labile mood and possibly self-injurious behavior. As levels rise further, drinkers can suffer incoordination, slurred speech, ataxia, amnesia, and impaired reaction times, and at very high concentrations, a lowered level of consciousness, respiratory depression, coma, and death. This, yes, can happen. Hints and tips. Extreme alcohol intoxication state can cause impaired concentration, inability to sustain attention, and global cognitive impairment, and can meet diagnostic criteria of delirium. However, this should not be confused with delirium tremens associated with alcohol withdrawal. Okay. Here we have a red flag. Alcohol intoxication can cause dangerous disinhibition, increasing a person's likelihood of having and acting upon thoughts of self-harm or suicide. 7 out of 10 men who complete suicide are intoxicated. This is very dangerous. Okay. Alcohol intoxication can be a potentially life-threatening condition due to the risk for respiratory depression, aspiration of vomit, hyperglycemia, hypothermia, and trauma like head injury, fractures, or blood loss following accidents or assaults. Hints and tips. Patients may report drinking alcohol in order to sleep better. This is counterproductive. It is true that alcohol reduces sleep latency and leads to increased slow-wave deep sleep during the first half of the night. However, alcohol also inhibits the time to onset and the duration of REM sleep, causing disruption to sleep architecture during the second half of the night and overall reduced quality sleep. Harmful use of alcohol. Harmful use of alcohol is when drinking causes physical, psychological, or social harm to the patient or others around them. People who harmfully drink are not dependent on alcohol. If features of dependence are present, the patient has alcohol dependence syndrome, not just harmful use of alcohol. Harmful use is just harm without dependence. Okay, so we talked about the box that lists adverse physical, psychological, and social consequences of drinking, yeah? No, not yet. Yes, here we are talking about complications of excessive alcohol use. Mental health. It can cause substance-related disorders, depression, anxiety, and so on. Self-harm or suicidal behavior. Socially, it can cause absenteeism from or poor performance at work or education. Victim of theft, wallet, phone, keys, unprotected sex with risk for sexuality transmitted disease or unplanned pregnancy, legal problems, increased risk for violent crime, drinking, driving, alcohol-related disorderly conduct, child abuse, and so on. Interpersonal problems, arguments with friends or family due to alcohol, financial problems like expense of drinking, unemployment, homelessness. What about complications on physical health, nervous system, intoxication delirium, withdrawal delirium, which is delirium tremens, withdrawal seizures, cerebral degeneration, cerebellar degeneration, hemorrhagic stroke, peripheral and optic neuropathy, Wernicke-Korsakoff syndrome, alcohol-related cognitive impairment. In gastrointestinal system, we have alcohol liver disease, fatty liver, alcoholic hepatitis, alcoholic cirrhosis, acute and chronic pancreatitis, peptic ulceration, and gastritis. Also, we have cancers, oropharynx, laryngeal, esophagus, liver, breast, colon, and pancreas. Cardiovascular system, hypertension, arrhythmias, heart, ischemic heart disease in heavy drinkers, alcoholic cardiomyopathy. In immune system, we have increased risk for infections, especially meningitis and pneumonia. In metabolic and endocrine system, we have hypoglycemia, hyperlipidemia, hypertriglycemia, hyperuricemia, which is gout, hypomagnesemia, hypophosphatemia, hyponatremia, alcohol-induced pseudo-Cushing syndrome. Hematological system, we have red cell macrocytosis, anemia, neutropenia, thrombocytopenia. Musculoskeletal system, acute and chronic myopathy, osteoporosis. For reproductive system, it can cause intrauterine growth retardation, fetal alcohol syndrome, erectile dysfunction, and infertility. It can increase the incidence of trauma, fractures, head injury, soft tissue injury following accidents or assaults. All of these are complications of using alcohol. So this is the harmful use of alcohol. Okay, communication. It is frequently useful to explain that although a patient may not be suffering from alcohol dependence, they are drinking at harmful levels and are likely to benefit from support to reduce their consumption, actually to stop it. What about alcohol dependence? After significant time of heavy, regular drinking, users may develop dependence. Alcohol dependence does not just mean physical dependence, although that is an important part of it, but describes a heterogeneous collection of symptoms, signs, and behaviors. We've talked about these previously. All of these, behaviors and, signs and behaviors which are determined by biological, psychological, and socio-cultural factors. There is range in the severity of dependence. One dependent drinker may experience a mild tremors and anxiety while at work, the fear, whereas another may shake so much after waking, and he is unable to drink a cup of tea in the morning without spilling it. So there would be a lot of symptoms. What about alcohol withdrawal, including delirium? The development of alcohol symptoms upon discontinuation of substance use is part of the dependence syndrome. We have books that summarize the continuum of clinical features of alcohol withdrawal, from uncomplicated withdrawal to life-threatening delirium tremens, DDTs. Where's the books? Here's the books. Clinical features of alcohol withdrawal. Started with uncomplicated alcohol withdrawal syndrome. Symptoms develop 4 to 12 hours after drinking cessation. These symptoms like, tremulousness, which is the shakes, sweating, nausea and vomiting, mood disturbance like anxiety and depression, feeling edgy, sensitivity to sound, hyperacusis, autonomic hyperactivity, tachycardia, hypertension, mydriasis, pyrexia, sleep disturbance, psychomotor agitation, all of these things. It may be with perceptual disturbances like illusions or hallucinations. Typically, these are visual, auditory, or tactile. It may be with withdrawal seizures that develops 6 to 48 hours after drinking cessation. Occurs in 5% to 15% of all alcohol-dependent drinkers. These seizures would be generalized and tonic-clonic. Predisposing factors: previous history of withdrawal fits, concurrent epilepsy, low potassium and or magnesium. Okay. What about withdrawal delirium? Delirium tremens. It develops 1 to 7 days after drinking cessation. The mean is 48 hours. Altered consciousness and marked cognitive impairment. Vivid hallucinations and illusions in any sensory modality. Patients often interact with or are horrified by them. Lilliputian visual hallucinations, for example. These Lilliputian visual hallucinations are miniature humans or animals. This is some kind. We have formication, which is sensation of insects crawling on the skin. There would be marked tremor, autonomic arousal, heavy sweating, raised pulse and blood pressure, fever, and so on. Paranoid delusions, often associated with intense fear. Mortality, this is important, 5% to 15% of people with delirium tremens die from cardiovascular collapse, hypothermia, hyperthermia, infection, and so on. Predisposing factors such as physical illness or hepatitis, pancreatitis, and pneumonia. These are some predisposing factors. Okay, withdrawal often precipitate vernix encephalopathy. The triad of ataxia, ophthalmoplegia, and acute cognitive impairment, risk for long-term cognitive impairment, the Korsakoff. Withdrawal is acute. Vernix is acute. Korsakoff is chronic. Korsakoff, chronic. Kors, chronic. KC, that's it. Okay. So, however, uncomplicated does not mean not serious. We've talked about that. All withdrawal states are potentially life-threatening if they are associated with autonomic hyperactivity or perceptual disturbances, which may cause a person to engage in risky behavior. Here we have a red flag. Always check whether previous episodes of alcohol withdrawal have been complicated by medical problems, such as delirium tremens or seizures, or psychiatric problems such as suicidality. These points will be important in determining whether detoxification takes place. Okay? These points will be important in determining where detoxification takes place. We'll talk about this when we talk about treatment. So, what about alcohol-related cognitive disorders? We have blackouts. Episodes of anterograde amnesia, blackouts, can occur during acute alcohol intoxication. Memory loss may be patchy or for a discrete block of time during which nothing can be remembered. Blackouts are common and have been experienced by 2/3 of dependent drinkers and 1/3 of young men in the general population. Blackouts refer to amnesia, not collapsing or passing out at the end of the night. They are evidence of hazardous use of alcohol as they place an individual at great vulnerability. So, blackouts may be evidence of hazardous use of alcohol. Okay. Wernicke-Korsakoff syndrome. Both Wernicke's encephalopathy and Korsakoff syndrome occurs because of thiamine deficiency, B1 deficiency. Although the two disorders were initially described separately, it is now clear they represent a continuum, with Wernicke's encephalopathy occurring during acute brain damage due to thiamine deficiency, and Korsakoff being the chronic state that emerges later. Any disorder that is associated with low thiamine can cause Wernicke-Korsakoff syndrome, or Wernicke-Korsakoff syndrome, but heavy drinkers are at particular risk. This is because of nutritional deficiency secondary to poor dietary intake and impaired absorption. Wernicke's encephalopathy, I say it's encephalopathy sometimes, encephalopathy sometimes, so it's okay. Wernicke encephalopathy is characterized by the classical clinical triad of delirium, ophthalmoplegia, mainly nystagmus, sixth nerve palsy or conjugate gaze palsy, and ataxia. So, delirium, ophthalmoplegia, and ataxia, which can be impossible to distinguish from intoxication. Delirium, ophthalmoplegia, and ataxia. This is for Wernicke's. All three triad components are found in only a minority of cases. The presence of any of them should prompt treatment. Early treatment with parenteral thiamine, which is Babrinex, can reduce the likelihood of progression to Korsakoff syndrome. Korsakoff syndrome is characterized by extensive anterograde and retrograde amnesia, frontal lobe dysfunction, and psychotic symptoms occurring in the absence of delirium. So Wernicke's, there is delirium in Wernicke's, ophthalmoplegia and ataxia, while Korsakoff is something else. Okay, here we have a red flag. The classic triad of Wernicke's encephalopathy is delirium in 82% of cases, ophthalmoplegia in 29% of cases, and ataxia in 23% of cases. However, all three features are not found in around 1 in 10 patients, and at presentation, 1 in 5 patients have none of these features. In someone who is withdrawing from alcohol, treatment with parenteral thiamine is required for anyone who is detoxing as an inpatient, anyone who is at high risk for Wernicke's encephalopathy, and the presence of any symptom consistent with Wernicke's encephalopathy. Treatment can always be stopped if suspicious if suspicions turn out to be unfounded. Dementia. Long-term alcohol excess leads to impairment of memory, learning, visuospatial skills, and impulse control associated with cortical atrophy and ventricular enlargement. This is called alcohol-related dementia. Withdrawal from alcohol is associated with cognitive impairment, which often does not fully recover. Alcohol-dependent people are also at risk for brain damage due to years of poor nutrition, trauma, head injury, and comorbid physical illness like alcohol liver disease. It is therefore important to screen for other causes of cognitive impairment, particularly reversible causes of dementia. Unlike with other dementias, subsequent abstinence from alcohol often leads to stabilization or some improvement in cognitive functioning. See Chapter 7 and 19 for more on dementia. Okay, we've talked about that in Chapter 7, and we will talk about a lot of these in Chapter 19. Hints and tips. Alcohol-related brain damage is an umbrella term which includes alcohol-induced dementia, Wernicke-Korsakoff syndrome, and amnesic syndrome. Abstinence from alcohol is often associated with some improvement in cognition. Okay, let's talk about alcohol-related psychotic disorder. The interplay between alcohol excess and psychotic symptoms is complex and is not as simple as cause and effect. While both hallucinations and delusions can occur in the context of heavy alcohol consumption, alcohol misuse is also a common comorbidity in many patients who suffer from psychotic symptoms, or let's say from disorders associated with psychotic symptoms, like schizophrenia, bipolar disorder, bipolar affective disorder, and so on. Alcohol misuse is also strongly but rarely associated with overvalued ideas or delusions of infidelity, like morbid jealousy or Othello syndrome. However, drinkers may experience psychotic symptoms that resolve or significantly improve with abstinence from alcohol and can thus be directly attributable to alcohol. These can range from fleeting perceptual disturbances with retained insight to more persistent auditory or visual hallucinations, alcoholic hallucinosis. To psychiatry, this is, persistent auditory or visual hallucinations, this is alcoholic hallucinosis. To psychiatry or grandiose delusions. These are distinguished from acute intoxication or alcohol withdrawal delirium by the absence of cognitive impairment and by clarifying when someone last had a drink. Psychotic symptoms directly due to alcohol are far rarer than psychotic symptoms due to comorbid psychiatric disorder. So, always carefully assess for the presence of other psychiatric disorders, even if a patient is drinking heavily. Alcohol-related mood disorders. Again, the relationship between alcohol and depression is complex. Heavy alcohol consumption may cause low mood, and similarly, low mood may cause sufferers to drink heavily to escape their difficulties. This problem is often compounded by the social damage that alcohol can have on patients' personal life and on relationships, marriage, employment, finances, physical ill health, criminality, etc. Differentiating low mood secondary to alcohol and true depressive disorder is very difficult and usually starts with abstinence following detoxification if necessary, because the potent psychoactive depressant effects of alcohol, pharmacological treatment of depression with antidepressants in a patient who continues to drink heavily is extremely unlikely to work and potentially dangerous. The first step in treating low mood is abstinence. Alcohol-related anxiety disorder. Up to a third of drinkers have significant anxiety symptoms. As in depression, establishing whether alcohol is a cause or a consequence of anxiety disorder is difficult. The anxiolytic properties of alcohol often result in attempts at self-medication in patients with PTSD, agoraphobia, social phobia, and alcohol withdrawal symptoms can mimic anxiety and panic symptoms. So the anxiolytic properties of alcohol often result in attempts at self-medication in patients with PTSD, agoraphobia, and social phobia. And alcohol withdrawal symptoms can mimic anxiety and panic symptoms. Patients often find it difficult to remember which came first, alcohol or anxiety. Whatever the direction of relationship, reducing alcohol consumption will be of benefit. Here we have a red flag. Self-harm and suicide are strongly associated with alcohol misuse. Over 50% of patients who present to hospital after harming themselves have recently drunk alcohol. Alcohol dependence is associated with a 12-fold increase in the risk for completed suicide. This may be due to alcohol-related psychiatric disorder, mainly low mood, comorbid psychiatric illness and personality disorder, and impaired judgment or disinhibition secondary to alcohol. Okay, we are done with alcohol. Let's talk about other substance-related disorders. It is beyond the scope of this book to describe in detail the individual psychiatric consequences of every recreational drug like alcohol use can be harmful, dependent, or result in psychiatric disorders such as psychosis. The effects of common recreational drugs are described in the table. Let's see that. Okay, here we have this table that is talking about these things. So, effects of common recreational drugs. For opioids like heroin, dihydrocodeine, methadone, buprenorphine, fentanyl, and oxycodone. These opioids have some mood and cognitive effects like euphoria, drowsiness, apathy, personality changes, and physical effects like meiosis, conjunctival injection, nausea, pruritus, constipation, bradycardia, respiratory depression, coma, or even death. Withdrawal syndrome from opioids may be something like muscle aches, nausea, piloerection, sweating, mydriasis, lacrimation, rhinorrhea, tachycardia, tremor, anxiety, irritability, short-acting opioid within 12 hours, long-acting within 2 days, lasts around a week. So these symptoms last around a week after 12 hours of short-acting opioids and 2 days after long-acting opioids. If there's any associated psychiatric disorders, non-typical. What about sedatives like benzodiazepines and others? If you have temazepam, diazepam, zepam, and the GHB, and and the gamma butyrolactone. So these can cause drowsiness and disinhibition, confusion, poor concentration, reduced anxiety, and feelings of well-being. And the physical symptoms would be hypotension, impaired coordination, respiratory depression. Withdrawal symptoms similar to alcohol, withdrawal with onset to duration depends on the half-life. These are something like seizures, hallucinations, sweating, tachycardia, tremor, and nausea. These are usually associated with substance-induced cognitive impairment. What about stimulants? Stimulants like amphetamine, cocaine, crack cocaine, MDMA, ecstasy, psychoactive substances, commonly stimulants. All of these can cause alertness, hyperactivity, euphoria, irritability, aggression, paranoid ideas, hallucinations, especially with cocaine. Would be something like fornication and psychosis. Physical symptoms like mydriasis, tremor, hypertension, tachycardia, arrhythmias, perspiration, fever, especially ecstasy, convulsions, perforated nasal septum with cocaine. And withdrawal would be something within a few hours to days of stopping heavy use. It would be something like dysphoria. This is what we call crash, yeah. Stimulant crash or cocaine crash. It would be something like dysphoria, fatigue, hyperphagia, nightmares, insomnia or hypersomnia, psychomotor retardation or agitation. It is associated with substance-induced psychosis and or mood disorder, triggering of manic episodes in patients with bipolar affective disorder. What about hallucinogens like LSD and magic mushrooms? It can cause marked perceptual disturbances, including chronic flashbacks, paranoid ideas, suicidal and homicidal ideas, and psychosis. Physical effects would be mydriasis, conjunctival injection, hypertension, tachycardia, perspiration, fever, loss of appetite, weakness, and tremors. Withdrawal, no specific withdrawal syndrome, and it is associated with substance-induced psychosis. What about cannabinoids like cannabis, hashish, and hash oil? These can cause euphoria, relaxation, altered time, perception, and psychosis. Physically, impaired coordination and reaction time, conjunctival injection, nystagmus, and dry mouth. Withdrawal symptoms generally are mild to moderate symptoms lasting for 2 to 4 weeks, like irritability, anxiety, low mood, restlessness, insomnia, tremorlessness, and headaches. What about dissociative anesthetics like ketamine and PCPs? These can cause hallucinations, paranoid ideas, thought disorganization, and aggression. Physical symptoms would be like mydriasis, tachycardia, hypertension, ulcerative cystitis, with no specific withdrawal syndrome associated with psychosis, of course. Inhalants cause disinhibition, confusion, euphoria, and hallucinations and stupor. Withdrawal would be like alcohol. No, physical symptoms would be like alcohol intoxication, like headache, nausea, slurred speech, loss of motor coordination, muscle weakness, nystagmus, also arrhythmia, pneumonitis. Chronic use would cause brain damage, liver damage, kidney and myocardium damage. Existence of withdrawal syndrome unclear. Around half of heavy users may experience hypersomnia, low mood, and nausea over the first days post cessation, associated with substance-induced psychosis, of course. So. Okay, differential diagnosis. Patients using psychoactive substances can present with features similar to primary psychiatric disorders, posing a diagnostic challenge. The relationship between substance use and psychiatric symptoms can be reduced to 3 diagnostic possibilities. First, there is a primary psychiatric disorder like depression or schizophrenia, and the patient is coincidentally using drugs or alcohol. Remember that patients suffering from mental illness often use psychoactive substances to obtain relief from their symptoms. Second, the symptoms are entirely due to the direct effect of the substance, and no primary psychiatric diagnosis exists. Third, psychiatric symptoms are due to a combination of above, as occurs when psychoactive substances are used by those with a predisposing vulnerability to the development of mental illness. The following features suggest a substance-related psychiatric disorder. The psychiatric symptoms are known to be associated with the specific drug in question, like psychotic symptoms with amphetamine use. These suggest substance-related psychiatric disorder. Another thing is there is a temporal relationship, hours or days, between the use of the suspected drug and the development of psychiatric symptoms. And there is a complete recovery from all psychiatric symptoms after termination and metabolic clearance of the suspected drug. There is an absence of evidence to suggest an alternative explanation for psychiatric symptoms like previous history of primary psychiatric illness or family history of psychiatric illness. Okay. Communication. You cannot completely exclude the use of substance or gauge the severity of established misuse without a collateral history, or in some cases even with one. Urine or oral toxicology screen are useful in establishing recent history of recent use of common recreational substances. Let's talk about assessment. The CAGE and audit questionnaire can be helpful in screening for alcohol dependence. Thorough clinical history should pay particular attention to all substances used, the pattern of use, the route of use, features of dependence, periods of abstinence or controlled use, reasons for relapse, previous treatments, and consequences of substance use, like in relationships, employment, physical health, criminality, and so on. The history of psychiatric illness and substance misuse, as well as family history of substance misuse, should be explored. Mental state examination is important to establish psychiatric comorbidity or sequelae. Current suicidality and insight into current substance misuse, whether the patient considers it to be a problem and what they would consider to be helpful. Here we have red flag. Taking multiple substances at once is a major risk factor for drug-related death. So taking multiple substances at once is a major risk factor for drug-related death, with recreational, prescribed, and over-the-counter drugs all implicated. The top 4 drugs involved in overdose are all antidepressants: heroin, diazepam, alcohol, methadone. Okay, these are antidepressants, heroin, diazepam, alcohol, and methadone. Always ask about polydrug use and whether the person has ever unintentionally overdosed. All patients prescribed opioid substitution treatment should be offered a take-home naloxone kit and training in how to recognize and treat an overdose. The CAGE questionnaire is a simple tool to screen for alcohol dependence. If patients answer yes to 2 or more questions, regard the screen as positive and go on for check if they meet criteria for alcohol dependence syndrome. First, have you ever felt out to cut down your drinking? This is C. This is CAGE. C, cut down. 2, have people ever annoyed you by criticizing your drinking? This is A, annoyed by criticism. G, have you ever felt guilty about your drinking? This is G. E, have you ever needed an eye-opener, a drink first thing in the morning to steady your nerves or get rid of hangover? This is CAGE, K, C, cut off, cut down. A, annoyed, something like that. G, guilt. E, eye-opener. The alcohol use disorder identification test, this is the audit, is a 10-item screening questionnaire for problem drinking developed by the WHO. It takes 3 minutes to complete and score and is recommended by NICE guidelines. Severity of dependence can be rated using the Severity of Alcohol Dependence questionnaire. Here we have a red flag. Always ask about driving and the patient's responsibility for caring for children. These are common areas of risk to others caused by alcohol or other substance use. Another red flag. General Medical Council guidance states that use of illegal substances and misuse of alcohol are fitness to practice use issues. This applies to medical students as well as qualified doctors and is intended to be supportive rather than punitive, aiming to protect patient safety while facilitating the doctor or student to engage in treatment and recovery. If you are misusing substances, contact your general practitioner and seek support from your medical school. If you suspect a peer or senior colleague is misusing substance in a way which may influence patient care, speak to a senior doctor or your medical school. About examination. The physical examination requires an awareness of both the acute and chronic effects of alcohol or substance use and should focus on evidence of acute use or intoxication like pupil constriction with opioid use, incoordination and slurred speech with alcohol use, and so on. Signs of withdrawal like tremulousness, sweating, nausea and vomiting, tachycardia and pupil dilatation with opioid withdrawal. Immediate and short-term medical complications of substance use like head injury following alcohol intoxication, infection used by intravenous drug use. Always inspect injection sites. Long-term medical complications like alcohol-related liver disease, hepatitis B or C or HIV infection with intravenous drug use. Investigations. There is no investigation that is absolutely indicative of substance dependence. A urine or saliva drug screening test is essential wherever the use of psychoactive substance is suspected. Saliva testing is more dignified than urine testing and is now most commonly used. Hair testing is occasionally used to get an accurate picture of drug use over longer time periods. However, toxicology testing generally is only set up to detect a limited number of well-known drugs, and testing laboratories will often not yet be set up to detect drugs which are new to the black market. Breath alcohol level via a breathalyzer only detects recent alcohol use. However, a high reading in the absence of signs of intoxication suggests some degree of tolerance, which is likely to be indicative of chronic heavy drinking. Investigations are also useful to identify possible longer-term complications of alcohol and include a full blood count. Mean corpuscular volume or MCV may be elevated, urea and electrolytes liver function test GGT may be raised, elevated ALT and or AST indicate liver injury, and high AST and ALT ratio suggests alcohol is the cause. So again, for complications like so MCV may be elevated, gamma GT, if there's anything with liver function, would be raised. ALT AST indicate liver injury, and if the AST ALT ratio is high, this suggests that the alcohol is the cause. Clotting screen like PPT and sensitive markers is a sensitive marker for liver function, and of course electrocardiogram. Hints and tips. If a patient is drinking too much alcohol, check their liver function. If a patient has abnormal liver function tests, take an alcohol history. Alcohol can cause abnormalities in any liver function test. If the patient has injected drugs, ensure serology for blood-borne viruses has been performed, hepatitis B and C, HIV, subsequent to the most recent injection. And consider the need to repeat test after a potential seroconversion. Signpost the patient to a needle exchange where they will also get access to a wide variety of harm reduction information and education, including sexual health issues. If the patient is suffering from a withdrawal delirium, brain imaging may be necessary to exclude an alternative cause or additional complication like infection, head injury, and stroke. Hints and tips. All patients, especially people presenting for the first time with psychotic symptoms, should have a urine or saliva drug screening test. It is important to collect the sample as soon as possible because the half-lives and hence detection windows of some drugs are short. Urine dipstick are the fastest way to get a result. Discussion of case study. Mr. AD has an alcohol dependence syndrome. You remember that case? Let's just say it. Mr. AD has an alcohol dependence syndrome as evidenced by his tolerance, withdrawal symptoms, relief of withdrawal by drinking, strong desire to consume alcohol, and continued drinking despite awareness of harmful consequences. If you don't remember the case, you can just go to the first of this video and you can remind yourself about the case, He has physical, sexual, possibly other systems, social, relationship problems, neglect of family and work, legal, drink driving offense, and mental, like depression, anxiety, and hallucination complications of his alcohol use. The first priority is treating the alcohol dependence. Following detoxification, it is important to assess his mental health to ensure that his depression, anxiety, and hallucinations are not indicative of primary psychiatric disorder. The visual hallucinations may be suggestive of withdrawal syndrome or be one of the perceptual disturbances sometimes caused by heavy alcohol use, alcoholic hallucinosis, although the latter is much less likely. Now you can go to chapter 20. We'll go then to that after, in its time, to read about alcohol and substance disorders and their management. Chapter summary. Here we are. Problematic psychoactive substance use can be classified as substance use disorders, including intoxication, hazardous use, harmful use, dependent use, withdrawal states. Substance-induced psychotic or psychiatric disorders, including cognitive impairment, psychosis, depressive episode, manic episode, and anxiety. Substance use is often comorbid with primary psychiatric disorders. Intoxication by and withdrawal from psychoactive substances can be life-threatening. When assessing substance misuse, don't forget to assess for impact on physical health and psychosocial function. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.